Start off with narrow complex tachycardias. Categorize them into two broad categories, AV nodal dependent and AV nodal independent. So basically, if you can do Valsalva maneuvers, give them adenosine, cardiac sinus massage, AV nodal dependent rhythms should terminate. If it's AV nodal independent, usually they're not going to terminate with those types of maneuvers. Getting a brief history was really important. If they have any history of structural heart disease, if they've had previous ablations for AFib, if they've had previous valve surgeries, it's more likely to be a reentrant type of arrhythmia, so less likely to be AV nodal dependent. If they're older patients, there's a bimodal distribution for AV-NRT. So older patients, I think AV-NRT is a little bit higher on the list for AV nodal dependent rhythms. And then if you have comorbidities, if they've had pulmonary disease or any other recent surgeries, kind of gives you the possibility of other atrial arrhythmias, right or left atrial arrhythmias. We don't really use this very much, but looking at your graphic trends on your telemetry, I think is a very nice feature that not too many people use. What you're looking at is basically if it's more of a sinus rhythm, sinus tachycardia, or automatic rhythm, you tend to have variability in your heart rate if you look at your cardiac trends. If it's more of a reentrant rhythm, it's more of a fixed rate, it's a flat rate. So this is kind of important if you have a patient that's been kind of trucking along at 110, 120 beats per minute. You're thinking it's sinus, but if it's really flat, I would kind of take a look again and see if there's maneuvers that you can do to bring out some other type of underlying atrial arrhythmia there. Okay, so this is a typical rhythm, common rhythm, typical AV-NRT. So narrow complex, and one of the key things here is that if you look at V1, you'll see this pseudo R1 in lead V1. You don't see it during normal rhythm, you see it during SVT. That's pretty classic for AV-NRT. This is atrial tachycardia, and if you just look at it offhand, it may just look like even sinus tachycardia. But the two key points here is that if you look at the P wave in lead V1, there's no terminal deflection in V1. And then also, if you look at the inferior leads, the vector is negative, meaning that if it's sinus in origin, it should be positive in 2-3 and AVF. If it's coming from down lower and going up towards your sinus node, then it's going to be negative deflection. So vectors here are very important for looking at the morphology of both the P wave and then later on, as we'll discuss, the QRS. Here's a response that you can see with the AV nodal dependent rhythm. So the patient's in SVT, you give them adenosine, and it terminates. So anything that has rapid onset, offset kinetics, and you can do adenosine, cardiac sinus massage, Valsalva maneuvers, and it terminates. And actually, if you look, it's a little hard to see up there on the slide, but if you look at V1, I think there's even a small P wave there. So that even kind of narrows it down to probably either AV-NRT or orthodromic AV reentrant tachycardia. Adenosine can actually terminate atrial tachycardia if it's a triggered mechanism. So it doesn't completely exclude atrial tachycardia, but the fact that it's ending in a P wave as opposed to no P wave makes it more likely to be a AV-NRT or orthodromic AV reentrant tachycardia. Okay, so what about this rhythm? What does this look like? We have a P before every QRS, and if we look over here on the inferior leads, those P's seem to kind of blend in pretty closely with the QRS. So if just at first glance, it may just look like a sinus rhythm, but there's actually P waves buried within the mid-terminal portion of the QRS here. And so you have to be a little bit suspicious. There's no way that this P wave can travel to this QRS. So there's another P wave buried here somewhere along the ST segment that's transmitting to the QRS. And this is actually not uncommon that we see after patients that have had extensive ablations for atrial fibrillation. They'll have these atypical atrial flutters the rate of the atrial arrhythmias will be relatively slow, and so your P waves may not always be apparent, and so you kind of look at these subtle changes in the ST segments and the relationship between the P wave and the QRS. You have to see, can this P wave conduct to this QRS, and the answer is no. So there has to be another P wave, so you search for that. And this rhythm right here looks like probably sinus rhythm, right? You have P waves in 2-3 and AVF. They look like they have a positivity there. You have a P wave here in V1. I don't really see any other deflection here. Now, this you may encounter in somebody that's had atrial fibrillation as well, because the key here is that the P wave lacks that terminal negative deflection. This is actually a right superior pulmonary vein atrial tachycardia. It's subtle, but we'll come across this again. So when I look at an EKG, I'm looking at the P wave morphology. I'm looking for a terminal deflection in V1. I'm looking at if it's positive in the inferior leads, and then I'm also looking at AVR and AVL and seeing, if it's sinus in origin, AVR should be negative. Here's an atrial tachycardia, and the key part here is you have this part, so you can see that there's block right here of this P wave, there's block right here of this P wave. But if you want to look at this rhythm here, what's more important is you look at this portion, the initial portion where it's beginning, and you can see that there's a P wave emerging from the T wave. And it's not so obvious here. In general, when you're interpreting arrhythmias, you want to look at where there is wobble in the heart rate. So you're seeing some fluctuation in the heart rate. You can kind of unmask some underlying P waves. So transition points are very important. Onset of the arrhythmia, any type of change in the heart rate, and termination of the arrhythmias. So these are very important points to kind of discern, is there another underlying P wave there? What's the relationship between the P wave and the QRS? Everybody can recognize this one. This is a typical atrial flutter. You have a sawtooth pattern here. In 2-3 and AVF, it's negative, okay? And in the precordial leads, you have positivity in V1. What I like to do is not just look at the 2-3 and AVF, because sometimes that will throw you off. Even if it's a nice sawtooth pattern, you really want to look at your precordial leads as well. So what I look at is that the terminal point of the V1, if you drop a line down from V1 down here to lead 2, there should be terminal positivity in lead V1. So that's more consistent with a typical atrial flutter. This happens to be a counterclockwise atrial flutter. So there's positivity in lead V1. There's a transition point in the precordium, so around V2, V3, it becomes negative. So this is pretty classic. And then here, again, you have a telemetry strip here. It's really not clear what's going on. You can do vagal maneuvers. You can do cardiac sinus massage. You can give a denocard here, and it just unmasks your atrial flutter. Multifocal atrial tachycardia. Sometimes you'll encounter these in patients that have pulmonary disease or post-op. What's important here is that at first glance it looks very irregular, but you can discern P waves, and the P waves have a different morphology with varying PR intervals. So this is important because you don't want to start this patient on anticoagulation. You want to treat the underlying problem, which is probably going to be a pulmonary disease or maybe something post-op related. Ventricular pre-excitation. So WPW, this is what EPs get excited about. I want to kind of break it up into several different categories here. So there's a WPW pattern. So what that means is that yes, they have pre-excitation, but they have no symptoms. What do we do for those patients? Well, you can do a couple of different things. You can do what we worry about with WPW is the risk of sudden death, the risk of having arrhythmias. So if a patient has no symptoms and they have pre-excitation, and you'll get this a lot, they'll do EKG screenings for athletes, young athletes, and you'll get this WPW pattern. You can put them on a stress test, a treadmill test, and if they have very obvious pre-excitation, and then you lose the pre-excitation at a certain heart rate, that kind of gives you an idea that the properties of this particular pathway is relatively weak, meaning that it's not going to be able to conduct very rapid signals from the atrium to the ventricle. And that's what we're worried about. You know, if the properties are such that it can conduct very rapidly, then that's where, if they develop atrial fibrillation, they are at risk of having sudden death. If they have WPW syndrome, that means that not only do they have pre-excitation, but they also have symptoms. If they have symptoms, they can be palpitations, they can be syncope, and there's a couple of different mechanisms here. You know, you can have orthodromic AV reentrant tachycardia. Okay, that means that the signal goes down the AV node and then back up the pathway. Okay, so that's going to be a narrow complex. They could have antidromic tachycardia, which means that the initial electrical signal goes down anterograde, down the pathway, and then back up the AV node. There's also another category in here where it's pathway to pathway. So in other words, they have two pathways. So they can go down one pathway and then come back up another pathway. And then, of course, this is the one that we're worried about. You know, if they develop some type of arrhythmia in the top chamber, atrial fibrillation, atrial flutter, normally our AV node has a filter on it. So over a certain heart rate, it's going to start blocking those atrial signals from reaching the ventricle. Well, when you have a pathway, that filter isn't really there. And it can allow signals to travel to the ventricle at a much faster rate. And in that situation, atrial fibrillation with rapid rates to the ventricle can degenerate into ventricular fibrillation. I do want to mention another thing about the WPW pattern. We talked about the fact that you can use some non-invasive testing, such as a treadmill. I think a lot of patients like this, we're kind of leaning more towards doing electrophysiology studies to kind of assess the properties of the pathway, to assess to see if the refractory period, meaning that how quickly the signals can travel to the bottom chamber without blocking, during atrial fibrillation, if that can be induced, and what the rate is as far as conduction between the intervals, the QRS, how short those are. So most patients, I think, if it's not very clear on the treadmill, you know, I think there's a lower threshold now to do an EP study. And then, of course, the risk of sudden death is low, but the risk is highest in younger male patients. Obviously, if they've had any evidence of atrial fibrillation with RVR, then that risk is a little bit considerably higher, and we would want to go ahead and proceed with an ablation. So this is just a WPW pattern. You guys can see the delta wave. You know, you see the QRS is wide. So this here, wide complex, very irregular, okay? And there's even some narrow complexes here. A young patient, no structural heart disease, kind of presents with this. This is probably going to be WPW with atrial fibrillation. So what about this? You had a patient who had WPW, you just ablated him. Dr. V went out and got a latte, and they're calling you from the floor, said, you know, your patient just had an ablation and he has these acute T waves. Do you get excited? The patient's not symptomatic. This is called T wave memory, okay? So, you know, there's a differential for deep inverted T waves. Obviously, you would think about ischemia, you think about myocarditis, you think about intracranial bleed. But if they've had a wide complex rhythm, i.e. Ventricular pre-excitation, pace rhythm, ventricular tachycardia. Once that rhythm converts back to normal, there's a delay in the recovery of the repolarization aspect, and so this is called T-wave memory. You may see this again. All right, and this EKG here, we're talking about narrow complex tachycardia. Any votes on what this might be? You have positive in 2-3 in AVF, positive in 1. Kind of positive across the precordium, but then you see this terminal deflection in V1. So just because we're talking about tachycardia doesn't mean we kind of exclude the obvious. So There are causes of sinus tachycardia, obviously. If the patient's septic, they've had a bleed. You don't always look for an arrhythmic mechanism. You also look for just normal physiology. I think Dr. Lamb's going to talk more about the medical therapy here. I'm just going to talk briefly about termination mechanisms that you may want to do. So start off with things that are at your disposal: vagal maneuvers, cardiac sinus massage, cold ice pack to the face. You could do adenosine. You can do calcium channel blockers, beta blockers. If the patient has no structural heart disease, you can do a pill in the pocket. If you do that for the first time for, let's say, AFib or atrial flutter, you probably want to do it in a monitored setting because sometimes what will happen is that if they're an AFib and they convert into a flutter, the flutter rate may be slower, and now instead of blocking the conduction to the ventricle, you may have one-to-one conduction to the ventricle, and so they may actually decompensate with that. Pace termination, some of these patients are going to be post-op. They have atrial arrhythmias. They have external pacemakers. You can use those to burst pace them. And then, of course, if they're hemodynamically unstable, you can use cardioversion. If you can't terminate them restore the rhythm back to normal, then obviously you want to try to rate control them. And this is going to be important for some of your patients that have AV nodal independent rhythms like atrial tachycardias, atrial fibrillation. So you're going to be at the bedside. The patient's post-op, post-cab. He has these externalized pacemakers. If you go down here in this menu setting, there's an atrial burst that you can apply. And you can actually, if they're an atrial flutter, you can pace terminate them. So use the tools that are available to you at the bedside there. I'm going to move on to wide complex tachycardia. So the differential for wide complex tachycardia is, of course, ventricular tachycardia. Aberrancy. So aberrancy means that they have a baseline bundle branch block, and now when they're in tachycardia, they still have that baseline bundle branch block, or they have a rate-related bundle branch block. So when they're at faster heart rates, the left bundle, or more commonly the right bundle, is not able to adequately accept that signal, and so there may be a block in the right bundle. If they're on flecainide, so sodium channel blockade, if they're on flecainide, you may get these bizarre-looking wide QRS complex. If they have any type of metabolic or electrolyte abnormalities, such as hypokalemia, hyperkalemia, you can get these bizarre QRS complexes as well. And the differential is pre-excitation, so any type of rhythm we talked about earlier, whether it's antidromic aviary tachycardia, atrial fibrillation with bystander conduction through the pathway. And then, of course, pace complexes can also cause a wide complex tachycardia. So this is kind of your differential that you have here. So again, use the tools at your disposal. Okay, look at their chest X-ray. Do they have a pacemaker? Okay. Less likely to be VTAC if they have no organic heart disease, maybe a paced rhythm. If they have a defibrillator, okay, so these kind of look similar, right? They have a implantable cardiac device. These are coils that go along with the high voltage lead. So this is a defibrillator here, okay. Ventricular tachycardia. When we think of ventricular tachycardia, we always kind of think of the worst, but there are actually some forms of ventricular tachycardia that are hemodynamically tolerant. We see them in patients with normal hearts. Those are the outflow tract tachycardias, the RVOTs. We're noticing more areas from the LVOT, the coronary cusp. The fascicular tachycardia, so they come from the anterior fascicle, the posterior fascicle. These are what we call the verapamil sensitive tachycardias. Scar-related tachycardias, we're all familiar with that, post-MI. You have other sources of scar as well, ARVD, ARVC, sarcoid. Bundle branch oriented ventricular tachycardias. Usually patients will have some underlying structural heart disease. There are cases where they may not have any depressed EF and still have this, but they usually have some significant underlying electrical conduction disease. So this is where the tachycardia results in the signal going down the right bundle, coming up the left bundle, or vice versa. These are very amenable to ablation. And then, of course, polymorphic ventricular tachycardia, which could be due to long QT, acute ischemia, a variety of other syndromes. So this may be one approach that you can take. I'm not sure I agree with this approach, but so you have a wide complex tachycardia. You can debate whether it's regular or irregular. Okay, if it's irregular, then you kind of consider these: atrial fibrillation via pathway, some other type of atrial arrhythmia. If it's regular, it could be aberrancy, could be antidromic AVRT. Vagal maneuvers are reasonable. I would be very careful with adenosine. If they have any type of structural heart disease, you give them adenosine. Okay, what do we use adenosine for? We use it for stress tests, right? So you're inducing ischemia. You could potentially induce ischemia. So you have a patient that comes in VT relatively stable. You give them adenosine, they can decompensate. So I would be very careful with adenosine. If it terminates with adenosine, does that prove absolutely that it's a SVT? The answer is no. There are some types of VT that can actually terminate with adenosine. Those are triggered VTs, the RVOT VTs. Looking at the relationship between the A's and V's, if you have it, great. A lot of times when it's a wide complex tachycardia, you may not be able to see that because the P waves are buried. So, if you're looking for AV dissociation, you probably only see that about 25% of the time. But if you have it, obviously it's very helpful. Obviously, V's greater than A's, for the most part, it's going to be VT. And then looking at the morphology. And when we look at the morphology, a couple of things to keep in mind is, if it's SVT, it's utilizing the normal electrical conduction system as the initial part of the activation of the ventricle. So that portion really should be very rapid and very narrow. If it's ventricular, whether it's ventricular pre-excitation or ventricular tachycardia, it's not going to be using the regular His-Purkinje system. So the initial portion is going to be slow and wide. That's number one. Number two, if you look at the lead one, if you look at lead one, your activation should always go from right to left. So you should have positivity in lead one. If you have what we call a northwest axis, okay, and you have a negativity in lead one, so it's going from the left to the right, well, that's not going to be sinus in origin, okay, or it's not going to be supraventricular in origin. And then, of course, when we do activation down the His-Purkinje system, there's going to be a transition point on your precordium. So you're going to have a mid-precordium transition point, and I'll kind of show you those. I like to use Brugada's algorithm. I think it's relatively easy to use. So the way we kind of approach this is, look at your, you have a wide complex tachycardia, and you look at the precordial complex. Are there any RS complexes? In other words, is there an R wave and an S wave? And if there's even one RS complex, then you have to move on to the next one. If there's no RS complex, meaning that all the complexes in the precordium are either all positive or all negative, well, that's VT. Okay. If there's any significant delay in the R to the S nadir. So again, this goes back to, if your electrical activation sequence is starting off in the His-Purkinje system, it should be very rapid. But if it's delayed, okay, again, that suggests VT. AV dissociation, if you see it, great, but you're not always going to see it. And then there's morphologic criteria, which they're a little bit more difficult to remember. But if you can't think of the underlying mechanism, I think it makes it a little bit simpler. There's another algorithm that also has some useful pearls to it, the DeBakey algorithm, where, again, if you see positivity in the initial portion of AVR, it's positive. Think of where AVR is. AVR is up here. So if your activation is coming from the top to the bottom, it should be negative. If it's actually going upwards towards AVR, it's going to be positive. So that's going to be VT. Okay, so here we have a patient that has wide complex tachycardias, having runs here. It looks a little polymorphic at times. And if we look at the QT interval, it looks pretty long. Just eyeballing it here, you can see that it's pretty long. So this is torsades. Okay, so you want to be able to recognize this and treat the underlying factors, correct their underlying electrolytes, discontinue any offending drugs. And there's a big list of drugs that can cause QT prolongation. So individually by themselves, it may not cause QT prolongation, but in a combination with other drugs and other abnormalities, you can definitely see this. So it's kind of important to know that, and no one's going to be able to memorize all those drugs. So even, I will look up drugs on a website there's called qtdrugs.org. So if you have any questions, this is a new agent here that you're not familiar with it, just look it up and it will tell you what the possibility is of QT prolongation with that drug. All right, so here we have a wide complex tachycardia, okay? So we can't really see P waves. What do we notice about the initial portion of the activation and across the precordium here? It's pretty wide, I mean, so this is what I want you to recognize. If you're using the His-Purkinje system, this initial portion of the QRS should be very narrow, and this is actually rather wide. So this is actually RVOT, or probably coronary cusp VT. So you have these very tall R waves in the inferior leads. You have this left bundle morphology, and you have this R wave in V1. So precordial transition is about V3. So this is going to be somebody with a healthy heart, and they present with this. This is one of those VTs that can actually terminate with adenosine. Okay, and it looks very narrow for the most part, but if you just kind of look at this initial portion, it's rather wide. And this is what I was talking about, looking at concordance. Okay, so it's a wide complex tachycardia. These are all negative. Okay, so all the QRS complexes are negative. This is probably an apical site of origin for the VT. Here you have positive concordance. So again, it's a wide complex. You look at the QRS complexes, they're all essentially positive. So this is probably coming from somewhere in the base of the LV, VT. Probably basal lateral. If you look at, again, you have a northwest axis here on lead 1 as well. And then what about this guy here? So again, the initial portion is very narrow. Okay? So it's very narrow, so that kind of goes along with aberrancy, okay? Because the initial portion is using the His-Purkinje system, so it's very rapid depolarization. Here we have a wide complex tachycardia. This is what you get, one of the things you have to use is, in addition to your history, if you have a baseline, if you have a previous EKG, just compare it, okay? And you can see that the previous EKG has this baseline right bundle branch block. Okay, so that was some type of SVT with the baseline bundle branch block. Okay, so I don't know if this comes up very well, but here is a VT, and it's a little bit harder to see, but if you kind of look at lead 2, there's some fluctuation here in the QRS, okay? And there's some changes in the T wave. So this is actually AV dissociation that we're seeing. So it's a little bit hard to discern. So the faster the rate is, the less likely you're going to be able to discern that. Okay, but this is AV dissociation, so that's VT. Here's a guy with a normal heart, comes in with this wide complex tachycardia. It actually looks pretty narrow, right? So initial thoughts may be, okay, well, this is probably aberrancy. Well, here's your clue right here. So you have a little capture beat, okay? So a narrow complex. So how do you get a capture beat? A capture beat means that in the setting of a wide complex tachycardia, all of a sudden the rhythm from the sinus gets in through the AV node and it depolarizes the ventricle. So pretty sure this is a capture beat. There may be some fusion. If you look at this beat right here, this actually has a lot more fusion to it, okay? So there has to be two sources in order to have this type of EKG. If you have capture beat and you have fusion beats, that means you have two competing sources of your tachycardia. So this was a left posterior fascicular VT. So it's a right bundle, and it's a it looks basically like a left anterior fascicular block. And the reason is because the VT is coming from the posterior fascicle. So your left anterior fascicle gets activated late. These are amenable to treatment with verapamil. They're easily amenable to treatment with ablation. But this is somebody that, you know, if you see in the ER, you can consider using verapamil if they have no structural heart disease. Okay, so you have this wide complex tachycardia here on the left. If you look on V2, you can see these pacer complex, the pacer stem, and then it breaks. So again, use the tools that are available for you. This was a pacemaker-mediated tachycardia. You can get a magnet, apply it to the device. When you apply it to the pacemaker, it basically makes it asynchronous, so it's no longer sensing, and it will break the tachycardia because you're breaking one of the limbs of the tachycardia. All right, what about this one? Artifact, yeah, very good. So, you know, we kind of put these up on the boards and we talk about in discussions, but, you know, how often does this really happen? You know, it happens quite a bit. And not, you know, I get these, I just actually last week I got one of my cardiology colleagues was asking for a consult for an ICD. So, you know, just take a moment. You can march it out, okay? Use your calibers, march it out. If it's not very clear here, you know, take 2 times the QRS complex and march it out. If it marches out, then it's not going to be, you know, VT. And then obviously use other leads. Use your, you know, your arterial line. If you have an arterial line, look and see if there's any type of hemodynamic response. So this is artifact, and we see it relatively common. All right, this is a patient has a history of AFib and now kind of presents with this regular wide complex tachycardia. And if you notice, it's actually shifting. We don't see this too often anymore because I think we're all kind of aware of using lower dosages of digoxin, but this is dig toxicity. It's called a bidirectional VT, and this is somebody that, you know, you'd probably want to use Digibind on. Okay, so management, of course, generally, if they're unstable, you defibrillate, correct all the electrolyte abnormalities, correct underlying ischemia, treat the heart failure. If they have an ICD, you want to go ahead and reprogram it appropriately. If it's scar-based VT, you can use IV amio, beta blockers if they're tolerant as far as blood pressure. I'll usually add lidocaine to IV amio. If it's torsades, you want to correct the electrolytes. You may want to give them additional MAG, isoproterenol. You may want to use pacing to get their heart rate up, obviously discontinuing offending agents. Brugada Syndrome, you may not see this too often, but you know, fevers can be a trigger for Brugada Syndrome, so you want to control the fevers. Quinidine, we don't really use it too much anymore, but this is one area where you can use it. And isoproterenol actually has some utility as well if they have VT storm. And then one last slide here. You're going to have a patient that comes in and gets shocked 25 times. This is intracardiac readings here. Is your atrial leads, and here's your ventricular lead, and here's your far field ventricular lead. You got noise here, okay? So this is a fractured lead. So you want to wait for the rep, or you want to put the device, the magnet on. You want to put the magnet on that disables the patient from getting any more shocks.